Thank you for the introduction. I'm Remy Rosenbaum, and today we're going to be talking about leveraging healthcare data and analytics to improve patient outcomes. So first we're going to start with a story about Edward Marks. He's the CIO of the Cleveland Clinic. I believe Stephen, who just presented, knows him when he was at the Cleveland Clinic. And the thing about Edward is that he's also a member of the national duathlon team. And during the national championships in 2018, he suffered a widowmaker heart attack. If that wasn't bad enough, a few months later, he was diagnosed with prostate cancer. And he credits digital technology to saving his life in both cases. He shared this information during a keynote, I think it was last month or the month before in Chicago. He thinks his life was saved because when he started his treatment, he told his cardiologist, who he called a little old school and not so hip on technology, to take a digital-first approach to his healthcare. And what does that mean? That means data from his smartwatch, data from his Bluetooth heart monitor, data from other external Internet of Things sources. And he was able to change his medicine regimen on a daily basis or near daily basis. What was the outcome? In 6 weeks, he was already back to running in his duathlon. And he says that he was already an evangelist for digital tools and digital transformation, but now it's my mission. And at Caserta, using data to improve lives is also our mission. So first, a little bit of housekeeping. Who is Caserta? So for those of you who haven't heard who we are, we're a data analytics consulting and implementation firm. We do strategy, architecture, implementation across end-to-end solutions. We help with strategizing and delivering an actionable roadmap on what you need to do to make your organization more data-driven. But we also do the harvesting of the data, sourcing of the data, pipelines, data architecture, data engineering, and data science. And we have a data science practice where we help organizations build out models. And I'll give you a few examples later on. These are our industry thought leaders. On the right, we have Joe Caserta. He's our founding president. He founded us in 2001. He wrote the industry best-selling book, The Data Warehouse ETL Toolkit. And on the left, we have Doug Laney, who some of you may know, but some of you may not. He used to be with Gartner as a VP, a distinguished analyst. He was the author of this best-selling book, Infonomics, who, if any of you would like, please talk to me and I will be happy to send you a copy. It's all about how to monetize and assess and value data as a real-world asset. And we have a Caserta Innovation Lab where we develop technology and frameworks and methodologies in-house so that we've done it before. We've worked with other healthcare organizations so we could come into yours and much easier and faster bring value to the projects. These are some of our really cool technologies we developed in-house. And we're helping you guys do amazing things with data. We are vendor agnostic. We do not recommend one over another if we do not believe it's best for your engagement. And that's important for us because we could come in and give an independent review of which technologies we think and which tech stack we think would be best for you, as opposed to a vendor who may tell you things that might not be completely obvious. Here's a few of our notable healthcare clients. We have Moffitt Cancer Center, who I'm going to touch on later, and a few others. With Humana, we actually did a story that was similar to Stephen's story about suicide prevention, which is an important project we did with algorithmic medicine. All right, let's talk about the presentation. So today I'm going to talk about the world of data-driven healthcare. All of us in this room are trying to use data in some form or another to push their healthcare. Whether we're payers or providers or life sciences, we're all trying to do this together. And this is what it looks like, the digital healthcare delivery ecosystem. So this is pretty much all of us in this room. We're all harvesting data and generating data and using data together in this new data delivery paradigm. And the only way this could work is if all of us in this room are in it together and sharing data and ingesting the data and making it happen. In the middle is the patient. And the only way to get a true longitudinal, holistic view of the patient is if we do this together. But of course, first we're going to go with the 4 V's. So if anyone's heard of the 3 V's of big data, so I did the 4 V's of big data in healthcare. These are models to think about data and how we can approach it best. So the first is, this was actually coined by Doug Laney, the same one who joined our company. He's the father of big data also, and that was in 2001 when he wrote a paper on the 3 V's of big data. So we did the 4 V's, which is volume, and that's because the sheer amount of data that we're all generating, that we have to ingest, this is data at rest. This is data that we've already harvested. Velocity, which is data in motion. This is your Internet of Things devices. So much data is coming through. How do you process it at real-time speeds? And the veracity. The more data you have, how do you know that data is good? Is it complete data? Is it a data that we can trust? I believe Angela said yesterday that There was data from one source. How can I trust it? This wasn't the data that I harvested on my team that I collected. I don't know the context of this data. And the variety of the data, which in healthcare is very challenging. So many sources, so many formats. How do you put it in one single pane of glass and make use of it? This is the data we're looking at. We have healthcare data, we have healthcare provider data, healthcare payer data, and life science data. All of these data types, all of them come in different formats. How could you possibly know which ones you need for what study, how to ingest them, and how to help a patient? This is unprecedented. We've never had access to so much data. But if we don't all share it with each other, how can we make use of it? We've structured data sources and unstructured data sources, which is a severe challenge. I'm sure a lot of you in this room have gone through this. How do you take a doctor's notes and turn it into meaningful information and data that you could use? We'll say you use natural language processing and machine learning. I'll get to that a little later. But how would you possibly put paper clinical notes and OTC medication and even Facebook postings, which could be an indicator for suicide prevention, all into one system? And this is exploding. It's just getting bigger every single day. All the time the data is growing. The average, it's estimated the average hospital will generate 665 terabytes of data, I believe it's a month, and it just keeps on growing. And how much is it growing? By this much. And if anyone could guess what an exabyte is, there's some scientists in the room, it's 1 quintillion bytes. That's a lot of bytes. And so this is the evolution of data analytics. We started with descriptive analytics, which is what happened. Moving to diagnostic analytics, which is why did this thing happen? Trying to explain it. But that only really helps if you're saying why something happened to a patient. We want to prevent things happening to a patient. So predictive analytics, what will happen to a patient, right? And then how can we make it happen? And then finally, self-learning analytics. Now the problem with this, as we learned yesterday from Ed, is in order to do AI, you have to have IA. And you can't do artificial intelligence and self-learning analytics if all your data is incomplete or not in order. So what are we going to do with all this data? We have a ton of data. And you know, big data is great, small data is also great, but we have all this data. How do we know what to do with it? What are some of the use cases? So here's some of the opportunities, and here's just a few. And afterwards, I'd also love to hear what are you guys working on and what are your opportunities with it. So how are we helping healthcare organizations with data? The first is obviously improving patient outcome and quality of life. That's what all of us want to do. That is our ultimate goal always. But also enhancing patient quality of care. We do want them to be more satisfied. And finally, it is a business. We want to boost economic efficiency and financial performance, and the bottom line is still as important as the other 2 points. So precision medicine is the first part I want to talk about. And all people are different. You know, each person has different needs, different economic factors, different ethnicities, different backgrounds, sex, height, weight, etc. And so we're moving really from a one-size-fits-all medicine approach to a stratified medicine approach, whereby people are in groups and not just as a one group all over. But then we could go on to precision medicine, and this requires use of genomics and omics data, lifestyle information, preferences, health history, medical records, compliance, exogenous factors. Many other factors go into this. And so how do we get all this data and feed that to a model or to an application that can make use of it? I said omics, just so everyone knows in the room. Omics represents the information contained within an individual's genome and the biological derivatives of those genes. This is very important for the work we did at Moffitt, which was on preventing tumors from regressing and how do we keep cancer at bay. And this is what we did with them. Precision oncology is how do we treat the tumors themselves? How do we give just the right amount of medicine at just the right time, at just the right place, without giving too much other side effects to the body? How are we going to cure this disease? And they believe that the answer is in this data. This is a brief bit about Moffitt.
For many, the sound of erasers clapping and the sight of equations on the blackboard may conjure up childhood memories of math class. But for Dr. Alexander Anderson, this may be the cure for cancer.
We're trying to use mathematical models to predict how a tumor grows and spreads in a patient.
Dr. Anderson is a mathematical oncologist at Moffitt Cancer Center in Tampa, Florida, the only cancer center in the world to house an entire mathematical department.
You know, mathematics classically has a bad rap as being something that's not applicable to the real world. But the reality of it is that mathematics is the language of life.
And life is exactly what's on the line when Dr. Anderson sets about solving the problem in front of him.
The things that's really cool about mathematical models is that I can run many different treatment scenarios through a mathematical model without ever applying them to a patient. So it's really a way to kind of predict the future based on the current state of the patient.
Dr. Anderson believes these models will ultimately produce better long-term outcomes for patients, but that doesn't necessarily mean eradicating the cancer completely.
And our kind of classic idea of treating cancers was to find the magic bullet. But what we find, especially with metastatic disease, is that when we treat continuously with a drug, that cancer will initially respond and then recur.
Using the theory of evolution, Dr. Anderson and his team in Moffitt's Integrated Mathematical Oncology Department use math formulas to determine the best course of treatment that allows a patient to control the cancer and actually live with the disease.
Basically, by applying treatments in a smart way, which could mean switching them on and off, we can control that cancer much more like a chronic disease. And so that leads to a situation of tumour control rather than eradication, but it potentially gives us a much more longer-term strategy for metastatic disease.
This form of adaptive therapy is tailored to each individual patient and is improving quality of life for those taking part in a clinical trial.
We've been able to control those cancers in 11 patients now for almost 2 years.
Since the patients are receiving a smaller dose of medication, Dr. Anderson says they have a higher quality of life and fewer medical costs. Just some of the benefits of controlling cancer, one equation at a time.
All right, at Moffitt, they're doing truly amazing things, and honestly, we're extremely proud to help them. That was for 11 patients in a clinical trial, and today we're helping them how to bring in all the data for all of their patients so that they could apply that across the organization. Our next example is patient monitoring, and this is how I use this example because there's many different players here all working together for one patient. This is an example of a patient in a healthcare facility monitored 24/7, and when something happens to them, they can take a photo of themselves. I believe someone said that yesterday about bed sores, when to determine bed sores, if it's a good example or not of how to treat it. And so they could take a picture of it and then send it through a system, and there could be machine learning to identify if this is a problem or not, and then how to send an ambulance or if there's other calling that needs to happen. But for this to work in practice is very difficult. All these players need to work together. The data sources have to flow, and all the data has to be understandable by all of these people. Data sharing must happen across all of these players. And here's an example of using predictive analytics for preventative care and cost reduction. We would ask a question: how can we prevent spinal surgeries from occurring? And when you ask this question, you first go through it and you would identify the patients who would do this, and then you would identify the variables which would lend themselves to needing it. And finally, with logical regression and using Bayesian inferences, you could actually build a model that shows which people are most likely to have spinal surgery. And then you can intercept, and you could do all kinds of things, like a physical therapy, or identify the other reasons behind this and try to prevent that surgery. So by 2022, the first US malpractice case will have already been heard involving an AI. It'll already be here, this is according to Gartner. And it will not be because an algorithm produced an incorrect diagnosis, but rather because of the failure of a healthcare organization to use that algorithm when another hospital could. If you had something that could determine sepsis and a different hospital did not, and a patient would pass away, unfortunately, they could be liable for that. This is by 2022. And so, if you don't embrace data-driven medicine, you'll not only be left behind, but you'll be endangering people's lives. And if we go back to what Edward Marks said, that is why it is his mission to push digital technology, and to have digital healthcare, you need data. So what are the challenges? Because this all sounds fine and great, but all of us sitting in this room have said, I've tried to do this, I can't do this, there's a million roadblocks. Healthcare is a monumental feat, and there's a lot more gravity here than GPS data or predicting the weather. I mean, if you make a mistake building like Waze or Google Maps, it'll add 15 minutes to your commute, right? But if we make a mistake, it can actually alter a human's life. And so with that gravity, we have to understand poor data quality is the main challenge, and this has always been a challenge in healthcare. Multiple sources and formats of data, interoperability. How can we all work together in this? How can we ingest all these data sources? I think Angela was saying you have 53 different EHRs, right? How do you make use of this data and understand it if there's so many formats? And finally, privacy and security regulations and restrictions, which we're all aware of, and data consumption. How are you going to consume this data? Who are the end users? Who are the stakeholders who are going to have to make use of this data and derive insights from it? So bad data in, bad data out. I think Ed even mentioned this yesterday. If you take bad data and you feed it to an excellent model, you will have a bad result. Super important. How are you going to ensure that the data is clean? How are you going to ensure that the data is accurate? How are you going to ensure that it's a complete view of a patient before doing this? If you're going to be having algorithmic medicine, you need to have good data. That's the first part. Second, data silos, which I think Ed also talked about, hamper growth and decrease efficiency. A data silo is, in each of your organizations, you have accounting, you have billing, you have research, there's clinicians, and each one would have their own data. Do they share it across the enterprise, or do they keep it to themselves? Especially in healthcare, we need to have different swim lanes so that certain people could see certain aspects of the data and others perhaps a more de-identified part of the data. And get out your phones. I'm actually having a webinar on this on Wednesday, so you can click that if you'd like. If not, you could take that down. I'll share it with you afterwards as well. And it's going to be all about how to eliminate data silos across your organization. And there's an overlap in data needs across the healthcare orgs. You know, there are all these different pathways. We have quality metrics, we have payer strategies, and they all overlap with their data collection. If you have different parts of an organization, each harvesting their own data, you'll have multiple sources of truth, and they won't be able to make complete decisions about that data. And again, all these different formats. How do you use unstructured data together with structured data? What about voice recordings? What about doctor's notes? How do you make use of it? And if you have all this data, you do have a more complete longitudinal record on the patient, and you can have better care. And so these are the challenges of personalized medicine. You have large patient populations that are needed to identify small subsets who will respond to the targeted therapy. How do you identify these people and find them if you don't have the complete data? Access to tissue needed for molecular profiling. How would you know which people have the right tissue that you need? Access to clinical data needed for model response to treatment. And finally, the ability to recontact patients needed to enroll in clinical trials. Trial matching is a big problem. I mean, many times they do trials and they can't find the right people to do it. It relies on each of these sections. You need lab values, molecular markers, comorbidity rates, staging, progression, toxicity, PROs, and survival. And if you don't have all of these things, you can't possibly have a clinical trial. Many times after 6 months, 7 months, even a year, you'll realize you only have 2 people to do a trial on, and that won't give you enough of a data set in order to derive an actionable insight from. And of course, compliance. How do you use all this data and share it with everyone and still remain compliant? It's a very big challenge that all of us have. And finally, how do you consume the data? You're going to be giving it to everyone in your organization to consume, but what are you going to do with it? I think Angela was saying that the rates of readmission improved because everyone had access, but not statistically significant. Improved because everyone had access now to these dashboards and they could drill into them. And finally, if we go back to the patient monitoring, each of these is not going to be able to communicate with each other if we don't have a standard across the organizations that we could communicate with. Now, if we go back to Moffitt Cancer Center, which best hospital, US News, high-performing hospital for the last 5 years, I believe, their promise of precision oncology is really the molecular characterization of tumors and how it will reveal the Achilles heel to cure the disease. But how are they going to do this if they don't have the right data infrastructure necessary? So Moffitt, who's actually pretty far along on their data journey, we met Dana Rawlinson from Moffitt, Dr. Dana Rawlinson from Moffitt, who we met with her and we helped her isolate all of their needs across the organization for their data. And we built them a strategic roadmap of our recommendations and how to achieve a data architecture which would include all these sources. We also helped them migrate to the cloud, but it's not necessary a cloud migration to do what we did there. And this enabled them to take all of this data and feed it into those models that we were talking about before in the video and actually help put cancer at bay, and one day, hopefully, cure cancer altogether. And that is their mission at Moffitt. So they knew that in order to do this, they needed the data, they needed clean data, they needed to make use of the data, and they needed to be able to deliver it at speed of thought to the right people at the right time across their organization. So what are our recommendations? Because that was a lot. So first of all, you can't boil the ocean. If you guys are thinking, okay, we're ready to do this, let's do predictive analytics, let's build these models, first you have to have a solid data infrastructure and know what you're trying to do. What are your business outcomes that are measurable and achievable? How are you going to show your upper management stakeholders what are you doing? How are you measuring quality metrics? And so, first of all, you need to have data dexterity as an integral capability for sourcing, curating, analyzing, and consuming the data. If you want to be working with external players and you don't have an architecture that supports data sharing, and all of this has to be automatic. Of course, there can't be any manual processes here because it would just be too much effort to do that and it would be very slow. So here is an example of what many of your architectures may look like. I'm not sure if you guys have exposure to this if you're not on the technical side. It probably looks more like this. It should look like this. So this is more of a modern data architecture, which we would recommend. We have all of our sources on the left, and then there's a curation and enrichment hub. This would cleanse the data, munge the data, blend the data before the data is delivered onward and upward. Then you have the organization of the data, followed by the preparation, which is models that we were talking about, advanced analytics, and finally, the analyzation and consumption of the data. And that would be dashboards and other metrics, feeding it to apps, feeding it to external organizations that would make use of this data. And that's also a method of data monetization. We talked about the bottom line, and how do you know what your data could be worth to other organizations? Of course, this would be a de-identified form of data, which you could then pass on. So how do you get started? First, document all of your data integration. First, you talk to us, right? Document all of your current data integration strategies and tools in use. And this might be tricky. You might not even know what you guys are using across your organizations, which is where an external player definitely comes in handy. Second, you need to inventory your healthcare ecosystem of data, interoperability, and integration needs. Each person and each organization is using different data sources, and that requires ETL in order to bring it into a format that you can analyze. You need to gather your metadata and begin to document characteristics of your data domains. What kind of data is this? What kind of levels of security do I need? Who has access to this data? And ask those questions. How do you catalog and tag this data so other divisions and other units can make use of it and understand where this data came from? And finally, conduct a gap assessment. How hard is it to get to where we need to go? And this is an honest look at the state of affairs inside of your healthcare org. It could be life sciences, it could be payer, it could be provider, but these are all the challenges we're looking at. And finally, align all the knowledge points you collected and put them together in a roadmap and strategy. So we also recommend developing an enterprise-wide strategy for analytics, which will lead to greater standardization of definitions that you could use, more accuracy in decision-making, efficiency, which you're going to gain from centralizing all this data, and of course, elevated sophistication of analytics and assets through data assets, through cross-disciplinary collaboration. And as we talked about before, there's a significant overlap in data types. You need to have an enterprise strategy which covers all of these data types across the organization. This is what a digital ecosystem looks like. This is all of our data flowing from all of our organizations to each other. And digital dexterity is impossible without data dexterity, and that's where your architecture comes into play. And this is how at Caserta we kind of value your data, because we say, what is your data really worth? And this is our methodology for coming in and interviewing stakeholders. First of all, what is the investment in your data? How do we govern this data? And like Stephen said yesterday, we're not doing governance for the sake of governance. We're doing governance because we're seeing how it affects key performance indicators. We're doing it to use this data, and how is it going to be useful for us? Innovation, monetization of this data, enhanced value. How much economic value will be given by monetizing these assets? And the life cycle expense of this data. This is a method that we look at for the data for our clients, which we call the corporate data pyramid. And again, this is a model for data governance. We could talk about it further if you meet me at the booth. And this is for analytics that we have. These are recommendations of organization, metadata, privacy and security, data quality and monitoring, business process integration, master data management, and information lifecycle management. And all of these are crucial for everyone in this room. And technology is a tool. It's not a magic cure-all. And this is one of the biggest problems. How do you get the doctors? How do you get the clinicians? How do you get everyone working together in order to make this happen across your organization? And change management is paramount to success. If you're not going to get people to be using this data and drilling into it and actually getting them to derive value from it, it's going to fail. And then stakeholders could say, this is why we didn't believe in it from the first place, whereas change management is key. At Caserta, we do retrain and reskill the people that we work with on our engagements in order so that they know how this is going to work. We identify champions, and we give them the tools necessary to spread the data gospel throughout the organizations. And finally, this is one sheet that I put together for you all about data-driven medicine. You can take a picture of it with your phone or go to here, and it'll be made available to you later. Thank you very much.